Hello and welcome to the second Kallmann syndrome webinar on Rare Connect. If you haven't already, please take a moment to join the Kallmann syndrome community today. Today's speakers are Dr. Andrew Dwyer and patient advocate Neil Smith, who will be discussing a recently published scientific paper. The paper aims to provide guidance for both patients and medical professionals dealing with Kallmann syndrome and other related rare conditions, and suggest preferred diagnostic tests and treatment options resulting from the combined experience of Kallmann syndrome medical experts from around Europe. So now over to Dr. Dwyer and Neil Smith.
Thank you.
Great. Well, thanks so much for having us. And Neil, thanks for the invitation to speak with you again. My name is Andrew Dwyer. I'm a nurse practitioner and PhD, and I work in translational research and clinical care of patients with Kallmann syndrome and congenital hypogonadotropic hypogonadism at the University Hospital in Lausanne. And I'm also proud to be the chair of the working group for our cost action on GnRH deficiency, which focuses on patient advocacy. And this is very strongly linked with the work that I have done with Neil over the last few years and other patient experts. So this paper was put together as a focus of our European network, which includes more than 150 clinicians and geneticists, bioinformaticians, patient advocates from across Europe, and basic scientists as well, who are interested in GnRH biology, and in particular, patients with Kallmann syndrome and CHH. So the focus of this paper was really to create a common ground, a consensus statement, if you will, on the pathogenesis, the cause of Kallmann syndrome and CHH, what is the appropriate type of diagnosis, and what is entailed in a diagnosis, and what are the relevant available treatments for this condition, including both for inducing secondary sexual characteristics and the outward signs of having gone through puberty, as well as fertility treatments. So this was really produced as a state-of-the-art paper to bring everyone in the field onto a common ground to state what is the best available evidence on diagnosis and treatment of patients, what are the best treatment options available, and what are the important questions that remain to be answered. And this was really a collaborative effort of this group of 150 collaborators. And we were really fortunate to have expert patients like Neil participate in this. And I will say, and maybe Neil, you can mention this a little bit, we had a meeting in Prato, Italy this spring, and it was the first scientific meeting that I have been at where actually we had patients talk about their experiences and share some of the difficulties and challenges that they faced to help clinicians and scientists better understand the patient perspective. So Neil, maybe you could say a couple of words about that event.
I attended the meeting in Prato in Italy with one of my fellow patient advocates from UK called Jan, and we were very happy to be able to attend this event because it gives us a chance to talk to clinicians, geneticists, and to researchers in the field, just to put our side of the story and just show what it's like to be a patient, and also just to keep up to date with the information and to see the sort of level of research that's going on into Kallmann syndrome and CHH at the moment. Because there is a lot of research going on worldwide, and just see how that could benefit patients. And it's useful for myself and other patient advocates to be able to talk to clinicians and pass on information back to patients.
Great. Well, I heard so many positive things from people in the meeting who were really appreciative to get the patient perspective. So one of the focuses of this paper is to try to put together, contribute to the tools that we've made available online for patients to better be able to take care of their health, as well as to have the tools available to help them advocate for the care that they need, as well as for other family members. So on our website for this consortium is gnrhnetwork.eu. It includes a list of specialist referral centers, different research programs that are ongoing, and we've been fortunate to have very generous help from our patient experts to help us develop lay language information that's put on the website for patients, which is being updated presently and hopefully will be online in the next month. But the whole focus is to give patients tools and help them understand what are the criteria for the diagnosis, what are the implications of this condition, what are the available treatments, and what are the things that patients and families can do to best take care of their health and to help their family members take care of their health and well-being. And in addition to many of the publications that have previously been put out, this is really represents, it cites 250 articles. It's from experts in reproductive medicine, endocrinology, genetics, and really presents the state of the art in the field in this. And importantly, it also includes a lot of work on the patient perspective in terms of understanding how Kallmann syndrome and CHH can impact the quality of life for many patients, and also some of the challenges that patients face, and to really try to raise awareness for clinicians to pay attention to this. And these are things like difficulty with intimacy and sexuality, difficulty with self-esteem and body image, and also transitions leading from pediatric care to adult settings. And I think that this is really a comprehensive document that really helps outline that. Neil, maybe you could share some of your thoughts. I think you've had a little opportunity to look at the paper and explain what you think about this work.
So I do want to make a slight of a point, because this is actually a European paper, and all these experts are European based, but it's for patients all around the world, and all the clinicians in European research centres work with clinicians in America and Australia as well, in like a in a worldwide collaboration, that's it, working together when they share information. So the information in this paper is relevant to patients in America as well as Australia. It's not just, but it is published by the European experts.
Absolutely, that's a very good point to bring up, Neil. Just because the title includes European consensus statement, it does not mean that this work does not apply to patients for all around the world. And indeed, the needs assessment that we conducted was done on the web, and this included patients from North America, South America, Europe, Australasia. So the themes and issues that patients experience are not individual to any particular continent. As you say, these are issues that are relevant for patients globally. And also we tried to take a very developmental perspective because this is a congenital condition, which is from birth. And so it presents differently, and the challenges and goals for treatment and health and well-being are different at different points in development. And that was one of the focuses that we wanted to try to carry through, so that patients around the world could understand what would be appropriate for infants who are identified very early, also for children with Kallmann syndrome, as well as adolescents and adults.
One thing I can see, as a patient, I first look at the document, it's like it can be about 30 pages long when I'm printed out. So it does seem quite a long, comprehensive document. But it is aimed for both patients and clinicians alike. It's a very good document to be able for patients to, when they see their doctors or primary care physicians, to say, this is a good reference material for them to look at as well, so that they can get their own information and see what is relevant and what is relevant to the patient at the time, and what is like consensus guidelines. Because it's a bit of a partnership between the patient and the doctor in the treatment given, because you have to, because it's such a rare condition, so quite a few doctors may not have heard about the condition or have patients with the condition. So it's sometimes helpful if the patient brings information to the doctor in a polite, helpful way and says, I found this information, can we discuss this information, and these are guidelines from experts from Europe and from around the world.
It's a really good point, Neil. Again, this type of review, this is widely read by general practitioners as well as endocrinologists throughout the world. It's a well-respected journal. And the intention is that it's written in a language not just accessible for a specialist in Kallmann syndrome or CHH, but rather is intended to be a document which could be understood by a patient with some knowledge, and certainly by primary care providers and endocrinologists who may not be specialists in this particular area. And as you said, many of the challenges that patients with rare diseases face are finding appropriate specialist care. And it's true that many patients don't live near a specialized center where there are experts and research programs and centers of excellence. So this is intended also to be a complementary tool so that, say there was a physician, a general practitioner, a primary care provider, or a general endocrinologist who maybe had not seen a patient with Kallmann syndrome before, this rare condition. And this would be provide some mileposts for this provider to be able to read this document and in a relatively short period of time, understand the basis of the condition, what are the available treatment options, as well as what is important for maintaining long-term health. Because for patients with rare diseases and other chronic diseases, it's very hard for people to stick with their treatments long-term. It can be very difficult sometimes to live with medical conditions. And so it's important for patients and providers to be able to have discussions to find out what works best, to find something, a plan, a treatment plan that is agreeable to both sides and that is attainable and that is feasible. And that's really what this document is hopefully intended to do, is to provide a lot of peer-reviewed information and the best available evidence for providers to be able to care for patients who they may not have, types of patients who they may not have seen previously.
There's three key questions or comments that often come up with patients that this paper does cover. I think if I can mention these three and let Andrew discuss or mention how the paper deals with them. Firstly, there's the issue of fertility treatment and how successful it can be with men and women with Kallmann syndrome. The issue of genetic testing. Now, is it relevant for patients, and how reliable or how much information can you get through genetic testing? And the postnatal screening for Kallmann syndrome in families where there's a known history of Kallmann syndrome.
Yes, those are very good questions. I'll take maybe the last question first. It's a frequent question that we often hear from patients, because many times patients with Kallmann syndrome or CHH are the only ones in their family with their particular condition. And oftentimes they will have spent much of their adolescence or early adulthood years really kind of stuck inside of a body that looks pre-adolescent. And this can be really difficult for patients. So the idea of early identification is very important. And indeed, when we start fertility-inducing treatment, overall, coming back to the first question, fertility treatment is quite effective for patients. In many causes of infertility in males and females, we don't have particularly good interventions. But Kallmann syndrome and CHH is a condition that fortunately we have quite effective treatments for in terms of fertility. In about 70 to 80% of cases, patients can achieve the potential for fertility, being that ovulation or developing sperm in the ejaculate. So the treatments that are available are quite effective. And there are studies and there's ongoing collaboration and work that is trying to customize and tailor approaches to really enhance these outcomes to make them even better. But oftentimes, as you said, patients are interested to know, what's my risk of passing this on to the offspring, my children? And this paper gives a quite detailed description of this, and I think it's worth reading. But in summary, really one of the things that is a benefit for patients to understand is that there is a very early window of opportunity in the neonatal life, in the first few months of life, wherein if we measure hormone levels, we can determine if someone has hypogonadotropic hypogonadism based on their hormone results. And in those cases, where it could be theoretically identified very early, then introduction of treatment could be made to keep development in line with peers, so that the offspring of patients with Kallmann syndrome wouldn't necessarily have the same type of social difficulties or psychological challenges of looking much younger than their age and not developing in line with their peers. So this isn't a very important aspect. Related to the genetics, that's also related to early diagnosis, because right now we know of more than 25 different genes that have been associated with Kallmann syndrome or CHH. And these genes are only accounting for about 50% of cases. So there's much more that we need to understand. And moreover, the more that we learn about these genetics, the more complicated it seems to get, meaning that sometimes several changes in several genes can interact and cause Kallmann syndrome or CHH. And this can be very difficult. Genetics can be very complicated, and I don't expect that all patients quickly understand all of these concepts. But the idea is that genetic testing can facilitate diagnosis, and in certain cases when the genetic cause is known in a parent, early screening with genetics could potentially be useful for identifying Kallmann syndrome or CHH in the offspring. But again, all of these things should be done in the context of discussion with experts and genetic counselors whenever possible, because as I said before, it's not just a simple equation. So the focus of this article, again, was to present the state of the art of what we know, and then what are the remaining challenges and the outstanding questions which we really would like to answer and need to answer to improve patient care and outcomes for treatment.
On the screen there at the moment is a list of all the current genes which have been implicated in Kallmann syndrome CHH, and that is quite a list already, and that's nowhere near comprehensive. And as you say, that's only 50% of cases. It does make genetic screening very, very difficult. And on the patient level, I think sometimes we're told the information a bit too basically. We're told, oh, a negative result means you're negative for Kallmann syndrome. Well, it's not always the case. You're just negative for the genes we can screen for at the time. So sometimes the patients don't always get the full picture when they talk about genetics or Kallmann syndrome. And just looking at that diagram there just shows how many different genes are involved, and there's no one easy answer with genetics and inheritance unless you've got a strong family history.
Correct. And a perfect example of that is this first gene, Cal1. That is often the most frequently screened gene because that was the first gene that was identified. And just because someone doesn't have a change in this gene that may account for their condition doesn't mean that they don't have a mutation or change in one of these other genes. So again, this is can be quite complicated, but genetics is can be useful both for clinical management and helping to clarify diagnosis, but it's also very useful for research because one of the things and one of the ways that patients with Kallmann syndrome and CHH have really helped advance the field is with generous participation in research studies and providing blood samples and samples from family members to help researchers understand and uncover the new genes, because the more we understand the genes that are involved in this and control it, the more deep our insight in terms of the biology, and it may also expand our ability to develop diagnostic tests which can improve early diagnosis and enhance this. It'll also enhance our ability to counsel patients on what might be the potential risk for passing their condition on to their children. And also, the idea is to ultimately translate all of these discoveries back to patients in the terms of tailored and effective treatments to really address the health needs in terms of the sex steroids, fertility outcomes, as well as quality of life and well-being that patients need related to their condition.
Would it be fair to say at the moment that most Kallmann syndrome patients get the same treatment regardless of their genes at the moment? But in the future, it could be you could get targeted treatment depending on what gene defects you're carrying. You could have targeted fertility treatment or hormone replacement therapy directed depending on what type of gene defect you have. It's not there at the moment, if I remember rightly, but it's a possibility in the future.
Yes, that's a very good point, Neil. We talk about personalized medicine and the idea that one day in the future that we could tailor treatments specifically based on someone's genetic makeup to really target and tailor the therapy to get the maximum outcome. Right now, that's not a reality, but I think this kind of consortium of collaborations across centers in Europe and across groups that were previously competitors, this is a positive sign for sharing information and beginning to, again, with rare diseases, it's difficult to advance the field because many groups may only have a handful of patients or a small group of patients. The more that we can share and bring this data together into, say, the shared database that we've developed through this European consortium, the more that this can be pulled together, the greater chance we will have for getting these types of insights and being able to tailor treatment based on or diagnosis based on someone's particular presentation when we see them in the clinic, or what treatment might give them the best chance at developing fertility. That's really the goal. But you're right, at this point in time, it's not a reality yet. But that's where we're working towards.
You mentioned briefly the levels of hormones being getting a peak just at birth in the first 6 months of life. This diagram here, I think, illustrates what you were mentioning. I just wonder if you can just highlight this diagram and show how this is different in people with Kallmann syndrome as compared to somebody without Kallmann syndrome.
Sure. And as I said before, we tried to take a developmental view, meaning at what does Kallmann syndrome or CHH look like at different points in life. And so this schema represents the lifespan. And this is in fetal life, the reproductive axis is active and hormones are produced, mainly driven by hormones from the mom. And you see this big surge. And this is the point where sexual organs are developing and all types of developmental steps are going on. And then this slowly diminishes. And then there's a peak again after in the first few months of life. And you can see that this peak is nearly equivalent to what you would see in an adult. So really, this is this window of opportunity in patients who may present with things like undescended testes or cryptorchidism or unusually small micropenis. This might be a clue that we could measure hormones to get an early diagnosis. And you can see in patients with Kallmann syndrome that that peak is not evident. Okay, you see this flat line across here. Now the challenge is during childhood, all children, whether they have Kallmann syndrome or not, are relatively flat. It's very difficult to detect any changes in hormone levels during childhood. And then this turns on during puberty. And some kids go through an early puberty. Some kids go through what's called a normal timing of puberty. And some children go through a late puberty. But patients with Kallmann syndrome or CHH lack this activation of their axis. And they never have this rise. So this is where they're resting down here. And these are different signs that one might be able to see at different points in development that might be indicative of CHH or Kallmann syndrome. So taking this developmental perspective helps us really understand what are the opportunities for diagnosis in these windows, as well as what are the signs that might be indicative of this. So one might imagine a teenager who is not going through puberty, and maybe they connect with you or another expert patient on Facebook group, and they start having discussions and learning a little bit more, and they're wondering if this might be something relevant for them. Maybe they are concerned that they have Kallmann syndrome or CHH. This document is intended to be a resource to help patients begin to develop a little bit of knowledge and maybe bring it to their physician and start a discussion. We don't expect patients to be able to diagnose themselves or treat themselves. What we want is to try to empower and activate people so that they can begin to take control of their health. And if they think something's wrong, that's the starting point for a discussion. And ultimately, it's that type of collaboration between patients and providers which really yields the best outcomes, and I think satisfaction with treatment.
Also mentioned in this paper, do you go through the different forms of hormonal treatment or HRT for men and women, and whether it's essential for people with Kallmann syndrome to be on treatment? And is there any consequences if people do not want to do not want to take any treatment, or refuse to take treatment, or get very late diagnosis? Is there any consequences later in life of not having the correct hormone levels in their later years?
Yes, that's a very good question, Neil. And many times we'll see patients, unfortunately, in early adulthood who have not been diagnosed, and they've gone long periods without having these sex steroids. When I say sex steroids, I mean things like in women, estrogen, estradiol, and in men, testosterone. So these hormones are not just important for developing the outward signs of puberty, like for women developing breasts and having a female appearing body with the curves and menstruation. And for men, the idea of deepening of the voice and increased muscle mass and developing a beard, the so-called virilization. It's not just those outward signs of puberty. These sex hormones have very important roles for lots of things in the body. Particularly, they're important for your bone health. So for patients who may stop treatment or maybe without treatment, they're at risk for having problems with their bones, either becoming brittle, like osteopenia or osteoporosis. And they're also at risk, there's some evidence to suggest they're at risk for developing metabolic problems. And what I mean by metabolic problems is this is when people may have difficulty controlling their weight, or they may have problems managing their blood sugar and developing diabetes or insulin resistance. These are problems which have wide-ranging effects. And so sex hormones are important for many aspects of health, not just the outward signs of going through puberty and fertility. So it's, even though someone may not be seeking fertility actively, and they may think, well, I don't need these hormones because I don't need fertility, or I'm not looking for fertility, it's still important to be on treatment for these other reasons. Not to mention also the idea of psychological well-being, that many patients feel much better on treatment. And this can be a real challenge with all medications and chronic conditions, whether it's diabetes or high blood pressure or Kallmann syndrome. It's difficult to continue to take your medications over 5, 10, 20, 30 years. But this is why it's so important to have these discussions with your providers and to really talk about what are the benefits and to understand why it's important to maintain your treatment to optimize your health.
I think that this paper looks a bit long and scientific for patients to read at first, but the way it's worded is being very careful to appeal and to be readable by both patients and doctors alike. And I would recommend that patients read this paper because it is very easy to read, and it gives a lot of information and up-to-date clinical information from a panel of the top KS experts around Europe with many years' experience of treating Kallmann's patients. And for patients to be empowered with their own information really helps with their treatment and being able to talk to their own doctors.
And like you said, Neil, it's a long document, but it covers a lot of things. It covers the biology of GnRH neuron development, which may or may not be of interest to patients. It covers genetics, which may or may not be of interest to some patients. It covers the approach to diagnosis. It covers treatment and breaks down even treatment into inducing secondary sexual characteristics or outward signs of having gone through puberty, and also fertility treatment. So I think, while initially it might be intimidating to some patients, one could imagine that maybe they just want to start with a section that's relevant for them, the introduction, and then maybe they're just interested in the diagnostic aspects or just the treatment. I think that it could be broken, each of those sections could be taken on their own merit. And hopefully it wouldn't be overly intimidating for patients, because ultimately we want to have this be a resource document And what we'll be working with, as you know, you've been very helpful in putting together descriptions in lay language that we'll try to put on the website, which are more abbreviated than this full scientific article.
It depends what stage of life you're at and where you are in the treatment process, or which bit is most relevant for you. If you're a parent with a young child and you worried you may have Kallmann syndrome, you've got the diagnosis, you've got the initial treatment to restore secondary sexual characteristics, you've got fertility treatment, and then you've got the osteoporosis and long-term benefits of being on testosterone treatment. So it's different sections will help you at different times. And there's a comprehensive paper that covers all of them. And I've never, there aren't, I don't think and there aren't many other papers out there that can provide this level of detailed and up-to-date information for patients and clinicians alike.
Well, as I said before, I mean, it includes, I think, almost 250 references, so it was a very comprehensive review of all the literature available, and it was a process of really contributions from people across Europe from different disciplines, andrology, reproductive medicine, endocrinology, and basic scientists, geneticists, and really giving a lot of different perspectives. It is very big, but our hope is that this would be a very sound reference document for both clinicians as well as provide an overview for patients and families. Again, literacy is always a challenge when we're talking about scientific literature, and the language that is often used is not always easy for many patients to understand. So one of the things that we'll be doing is trying to provide really concise lay language information on our website to complement this document. So for those patients who may have difficulty understanding the language here, that we'll try to make it in perhaps a little bit a simpler, more concise description.
And I do meet patients within our Facebook groups who are very up to date with the information, and they want this level of information, and they're able to relate it back to other patients and be able to explain it in layman's terms or terms that patients can more readily understand. And it's good to have patients who are able to have that go-between between the clinicians and other patients to be able to relay information between each other.
Well, I think it's very important because, you know, as clinicians and scientists, we may understand the pathophysiology and the genes that cause Kallmann syndrome and CHH. We understand the medications and how to treat it, but we aren't always good about understanding what it's like to live with Kallmann syndrome on a day-to-day basis. And that's really the domain where patients are experts. So my hope is that this is really complementary, that there's expert, peer-reviewed, scientific, medical information provided, and that can be complemented with expert patients who know what it's like to live with this condition, and like yourself, who are very knowledgeable about the genes, the treatments, and outcomes for this. And I think that's a really powerful benefit for patients, because with rare diseases, oftentimes patients feel like they're the only one. They can often feel isolated, and these are intended as steps to try to help pierce that veil of isolation and help connect patients with others who can help them get linked in with providers who understand their condition, and connected with other patients who can help support them if they're having difficulty with some parts of their condition.
Thank you. I think we covered quite a lot today. Thank you very much for your help there. I would like to hope we can do some more of these seminars one day where we can ask experts like Andrew and his fellow experts questions directly that patients have, so we can have direct question and answer session by video. And I think it's also a good chance for patients to be able to meet other patients in a seminar room like this.
I think that sounds like a great idea, Neil. Thanks.
Yeah, sounds like a good idea, Neil.